UroPatient. Tune in and see. Prepare your health for you and me. Knowledge is power. We make it clear every Saturday morning.
Hey, good morning, everyone, and welcome to UroPatient Podcast. I'm your host, Vic Senese. Welcome to the show. Hey, if you're checking us out for the first time and you haven't liked and subscribed, what are you waiting for? Like and subscribe. So today's episode is really going to be a little different. I'm going to talk about prostate blockage and the best treatment and what's known as the gold standard. Actually, I'm not going to talk about it. I've got a guest star coming on, Dr. John Lynn. He's a urologist out of Arizona, and he did a recent talk on UroNurse, and I'm going to go over his talk and kind of explain some of the technical parts during the talk, but I'm going to bring him in to explain why the gold standard is what's been done for years. Back when I first started 40 some years ago, there was one treatment for blocked prostates, and that was called the TUR, the prostate, where we would go in there and channel it out. And, you know, it's kind of was the gold standard then. It's still the gold standard, but we'll let John tell you why it is.
Today, we're going to jump right in to talk about BPH, or benign prostatic hyperplasia, enlargement of the prostate, basically affecting over 40 million men in the U.S. every single year. There are not enough urologists just to take care of this problem. So there are a lot of options out there, and I happen to be very passionate about TURP, which happens to be the gold standard when it comes to managing enlarged prostates. And let's begin by talking about who discovered this thing. Well, a guy named Maximilian Stern in 1926, believe it or not, 100 years ago, developed the Stern resectoscope. And he has a slightly color history when it comes to the AUA and Dr. Stern. So somehow he got kicked off, and then I don't know if he ever got back on the AUA rules. But he developed the Stern resectoscope back in 1926. That's 100 years ago. So this technology has been around for a long time. It stood the test of time. Early limitations, I mean, it cut really well, but then it didn't stop the coagulation. It didn't stop the bleeding too well. Coagulation was not very good. Lighting was not very good. There was significant bleeding, some technical challenges. And in 1931, Dr. Davis modified the resectoscope, added a bigger viewing angle, wider loop to cut the tissue, and cutting and coagulation currents that you can control with the foot pedal, which is how we perform TURPs now, with the foot pedal, one pedal for cut and another pedal for coag. And then you have Dr. McCarthy, who combined the improved optics with the Davis-Stern concepts and added some insulation to create a new resectoscope, which became widely adopted. And in the 1940s, Dr. William Milner and others refined the technique and demonstrated in a large series that this is a safe and durable procedure, and it became the standard it is today. So what makes something the gold standard? Well, first of all, it has to be very effective in treating the patient and relieving his symptoms. Not only that, the patient has to do well after surgery and during the surgery. So low morbidity is super important. And I don't know if you know this, but 18% of GDP, or $1 in every $5 in US economy, is spent on healthcare. So for something to be the gold standard, it has to be of low cost. And lastly, when I do something, I want to do it once and not have to see the patient back for a long time, if ever. So it has to be durable. And let's talk about TURP, one of the potential complaints of TURP, which is retrograde ejaculation. Retrograde ejaculation. When I tell my patients and when I counsel him, we're going to do a TURP, I tell these patients, instead of the 36% chance of not having retrograde ejaculation.
So let's stop a second and talk a little bit about what is this retrograde ejaculation. So normally when a man ejaculates during sex, the semen comes forward and comes out the tip of the penis. Retrograde means it backs up into your bladder. And the reason for that is when you do a TURP, you're scraping out tissue, and part of the tissue, when you open it up, it actually becomes easier for semen, which is produced in the prostate, to back into the bladder than it is to go forward. Now, normally during an ejaculation, there's actually two valves inside the bladder. And when you urinate, the opening of the urination one allows urine to pass forward. But the one behind it stops the or stops it from. So when you ejaculate, then what happens is you need to have the bladder one stay closed and just the front one. So when you urinate, both open. Had that a little bit wrong. But anyway, retrograde ejaculation then is the backup of that semen into the bladder. It's not anything dangerous or something problematic, but for some men, you know, they want the sensation of something coming out of the penis, and that gets destroyed. However, it is still, with the gold standard, the best way to go. And Dr. John's going to explain a little bit more about it.
You almost always will have retrograde ejaculation when I perform your TURP, because I'm resecting a lot of tissue, especially the apical tissue. I'm removing that tissue, which will generally cause retrograde ejaculation. However, in my frequently asked questions sheet that I give to the patient, and I tell the patient, if you're so inclined, if you're worried about retrograde ejaculation, I got you, buddy. There's something called ejaculation preserving TURP. Yes, that's correct. I can perform a TURP in a way so that I can preserve the ability for the guy to ejaculate antegrade. So there is ejaculation preserving TURP. Just because your urologist doesn't know about it, doesn't do it, doesn't mean that it does not exist. You can perform ejaculation preserving TURP. The downside of ejaculation preserving TURP is that I'm not removing as much tissue. I like to do the procedure once and not have the patient come back ever. When I do an ejaculation preserving TURP, I'm removing less tissue, so there's a greater chance of symptomatic recurrence. So I tell the patient, I can preserve your antegrade ejaculation, but most likely you may come back sooner than expected. So let's take a look at what a typical TURP looks like. And this is so if you see that silver loop that just went into the bladder, that is the loop that I use to perform the.
Now, just to explain, what you're looking at is what the doctor sees through that cystoscope, the one he said was invented probably 100 years ago, with the resecting loop. And you're going to see this loop cutting the tissue, and that's how it works. It's kind of interesting. I always kind of think it's sort of like when I cut cheese with the wire, you know, when you slice it. So it is the same thing. It's a wire that slices. However, it coagulates or burns tissue at the same time.
When I press the pedal that is cut, it shaves away that prostate tissue. And what I'm doing right there is cutting away the median lobe, or the part that's coming up from the backside of the prostate. And I'm systematically just slowly taking it a little bit at a time. And this is a good sized prostate. I take a little cut and more seems to come up posteriorly in the median lobe. And I just systematically cut away. And I cut away that median lobe first because water or saline is running towards the bladder away from us. That is why the visualization field is so clear. And this is what happens during a TURP, resecting the median lobe. Every slice, I'm removing a little bit of tissue at a time. I'm using saline. It is a bipolar resection. It is safer. There's no TUR syndrome like in the past. So this median lobe resection.
I'm going to stop it right there because some you folks may not understand what he's talking about. So in the past, we used a solution because it was not bipolar. It was what we call monopolar. You had to use a solution that wouldn't transmit electricity, but the body would absorb that fluid. And so you had to be careful because you only had so much time, and you would absorb too much fluid into your system and start diluting your blood. And that could cause a drop in your sodium, and it's what he's referring to. That's why it's dangerous. Now, they've since come up with this, what's called the bipolar, which allows us to use saline solution. Saline is what your blood is. It's salt water, basically. And by using that, it's not absorbed because it doesn't transfer through back and forth through the membrane because of a difference in concentration. So it makes it safer to go ahead and do a more thorough and a longer procedure, which is what he's going to refer to, because one of the big disadvantages of a standard TERP is you have to be hospitalized for bleeding. Again, the docs are trying to go as fast as they can because they had limited time before you'd absorb too much fluid. But now with this new system with the bipolar, they have more time that they can work to do a better job and not worry about this fluid intoxication that he was referring.
Is going very smoothly, very quickly. All that tissue is being removed, which at the end of the case, I will suck it out of the bladder because all that tissue is going into the bladder. At the end, I will just suck it out using a device that removes all that tissue. Unlike a PVP, we actually have tissue to analyze. And rarely, but not infrequently, this tissue will come back showing prostate cancer.
So again, he's referring to some of these other treatments that are minimally invasive. Now, the PVP is using a laser where you're just vaporizing the prostate. And all these other things where we just do like Optilooms or Rezooms or staples, all those things that we can do that are considered minimally invasive have no tissue removed. And what he's referring to is sometimes this tissue that they remove with the scraping goes off to the lab to be analyzed by the pathologist, and they may find cancer. So you may have saved yourself a misdiagnosis down the line. So that's kind of a bonus.
So having tissue is beneficial in my experience. Now you may be thinking, oh my gosh, that loop is huge. That prostate seems so big. Well, just to give you some perspective, images appear larger than they are in the video. But this is how big the loop is. This is the actual instrument that is used to do the resection. The loop is at the very tip right here. So you can imagine how small that semicircular loop is. It's right there. That is how small it is. So the instruments that are being used during a TURP is actually really, really small. And what happens? What does it look like after a resection? It looks like this. This is immediately during the case at the end of the surgery, what the prostatic fossa looks like. It's a wide open channel, wide open channel. So this is immediately during surgery at the end of the resection, you've got a big open prostate. So not only is it wide open, this is, I'm soft flexing here, soft flexing. To the urologist who's actually doing the surgery, you can see that there's absolutely no arterial or venous bleeding. And to the astute urologist, he or she will see that there's absolutely no inflow going, meaning I have the fluid turned off. There's no fluid running into the bladder. The ultimate test to make.
So now what he's referring to is while you're doing the procedure, you always have fluid going in to push the blood away so you can kind of see what you're doing. But he's finished, so he's not running any fluid in there to clear off any bleeding. And you can see that there's no active bleeding. And that's because he's able to take his time and cauterize or burn all the little blood vessels that were involved with resecting all that tissue out. And when you can do that, you can get what we call a very clean or not bleeding field. And again, early on, 40 years ago when I started, the patients came out of that with a lot of bleeding because that was, again, we told you had to do it fast and you didn't have the time to spend to really seal all those little vessels. You just waited till they sealed on.
Perfect hemostasis. Perfect hemostasis. So that is what I strive for when I do a TURP. There's absolutely no bleeding at the end of the case. And what does that look like in the recovery room? For the recovery room nurse. This is a photo that I took actually just a few days ago in the PACU, post-anesthesia care unit of a TURP patient. I want my irrigation fluid to look like that at the end of the case. So what does this look like in the
So again, for those of you that are, don't see patients right after surgery like I did, that's unbelievable. You never see a clear bag. It's always red. A couple of drops of blood turns everything red. So it doesn't take much blood to make the color of the water red. But what we're doing after surgery is we hang a bottle of fluid that's constantly washing. So it's got a special kind of catheter called a three-way catheter. So fluid can go into the bladder and the fluid could come out of the Foley catheter, out of the catheter. And what you're seeing in the bag is the color of how much bleeding there is. When you get a bag that's clear, there's no bleeding going on, which is, like I said, pretty remarkable. Now, if you stopped it, you might see a little bit of blood because it does have some bleeding, but it's so small that you can actually keep it pretty clear. I can tell you that that's a nurse's dream when you have to keep up with trying to make sure you're washing it out. And the reason you have to wash it out with irrigation afterwards is if you don't, the blood is going to flow back into the bladder and form clots because that's what blood does. Well, what is the clot going to do? It's a big old marble in there that's going to block the hole of your catheter. Pretty soon your bladder is going to start to descend and you're going to be pretty uncomfortable. So we have to keep it washed out for that reason. All right, let's go back to Dr. John Lynn.
The way I do this procedure is I do it as an outpatient in a surgery center. So this is done as an outpatient. There's no prolonged stay. When I do it and keep the fluid nice and clear, have perfect hemostasis at the end of the case, there's no prolonged stay in the recovery room. And I know those of you who have worked in a recovery room taking care of these TURP patients, or those of you nurses who have worked on the floor in the past, or maybe even now, depending on where you work, you're taking care of these patients post-op with the CBI, and the CBI is constantly running out, and you have to you have to empty the bag, you have to now take the bag out and drain it. It's a big pain in the butt. It's more workload for you. Well, I'm very empathetic to my nurses. I want to make your workload as low as possible. And that's part of the reason why I do it this way. Perfect hemostasis, minimal amount of time in the recovery room, minimal amount of flow with the CBI, so you don't have to constantly hang new bags and then drain the effluent, the bag all the time. That's a lot of work for you. And you're taking care of sometimes multiple patients on the floor. And now I'm asking you to spend all this time, dedicated time, taking care of this one patient. I'm not being sympathetic. So I don't want to do that. So I will put in a little bit of work in the operating room to ensure perfect hemostasis before the patient goes out to the recovery room.
Again, he's speaking to a group of nurses that I had him on for a show. And, again, as a nurse, that's huge when you don't have to try to keep up with this CBI, because these things have to be draining pretty fast. I mean, we're dripping a solution in pretty quick, and you got to turn over the bottles. If they run out, it's going to stop, and you're going to have issues where you might have a blocked catheter. Now, that's their side. As a patient, again, if your catheter blocks, that's going to be uncomfortable. Even more uncomfortable is if it blocks, we're going to have to go in there and try to manually suck out those clots with a special evacuator. It's not the most comfortable thing. So even though he's talking about how he's making our nurses' lives easier, he's making your life a lot easier too, because trust me, you don't want to have us go in there and try to irrigate out clots.
Some of you surgeons are saying, yeah, I know, John, I can do that. But sometimes when you get into the recovery room, you still see a little bit of bleeding. Yes, I totally get it. Yes, I do that. That happens to me as well. And it is okay. Do the best you can in the surgery. Make it look like that so that it's perfect. Take that extra few minutes to do that so that you don't have to keep the patients in the hospital and round on them the next day, or have your APP round on them. That's resources that can be used to take care of the next patient. There are over 40 million men in the US with this problem. Not enough of us just to take care of TURP or BPH patients. Okay. In addition, when I do it this way, my catheterization time is less than 24 hours, meaning I put in a 3-way catheter into the patient at the end of the case. That catheter is removed in less than 24 hours. That's one of the biggest complaints for patients when it comes to TURPs. They always ask, do I have to have a catheter? How long do I have to have the catheter? So I tell the patients beforehand, before surgery, yes, there will be a catheter, but the catheter stays inside you for less than 24 hours, less than 24 hours. And no one's ever complained when I tell them that.
Well, if you never wore a catheter, they're not the most comfortable thing. I've actually gone through and had a catheter myself. So getting it out sooner is really a relief. There's lots of issues with the catheter. One of the things that patients may not know is that catheters come in different sizes. The normal size catheter, if you went into the hospital because you couldn't urinate and they put a catheter in you, would probably be what we call a 16 French, fairly small catheter. Um, if you have the surgery done, we normally put a 24 French. Now it goes in routes of 2 to get bigger: 16, 18, 20, 22, 24, 5 times larger. So it's much bigger catheter diameter wise. It's going to be less comfortable to have that inside you for any length of time. Normally, in the old days, when we did the procedure, we had to keep the flushing going for at least 24 hours. If it slowed down, which meant you had to stay in the hospital overnight, he says outpatient, you go home the same day. That's huge. Sit in the hospital 24 hours with this fluid going in the morning. My job was to come around and turn that fluid off if it looked like it was starting to clear up, and then come back a little bit later, like an hour later, to see if it stayed pretty clear and was still running. Then we could consider sending you home with that catheter. Wouldn't come out. We'd take the catheter out in the office. So big difference. It wasn't going to be a 24-hour thing. It may be several days.
4 hours. And the medication that I prescribe for the patient, only 2. So almost 1 in every $5 in the U.S. economy is spent on healthcare. I'm going to do my part to minimize that cost. And that is phenazopyridine or azo and an antibiotic of your choice. That's all I give to the patient. Now, this is great, right? What a great story. Durable, no stay in the hospital, and catheterization time in less than 24 hours. Well, just like your car, right? They'll test your car for fuel economy, and EPA will say this will give you 35 miles to the gallon. When it comes to TURPs, just like a car's fuel economy, your mileage will vary depending on the surgeon's experience and possibly his or her patients in the operating room to achieve the desired results. His or her experience dictates how efficiently the procedure is done, how long it takes for the procedure, and also the patient outcome. Believe it or not all urologists do TURPs the same way. Even though the procedure is TURP, not all urologists do it the same way with the same efficiency.
So that's a good point. And every patient is going to vary. You may even have, Dr. Lin or somebody use a bipolar system like he uses, that same technique, and have more bleeding than expected. It happens. There's different reasons why that could occur. But for the most part, the larger percentage done that way don't have that bleeding and have a much quicker recovery and all the good things that I talked about. And trust me, like I said, I've been doing this for 40 years plus, and I've taken care of a lot of patients in the old days because that was the only thing we had was the TURP. Now, I hope you enjoyed that, because that really, I wanted to kind of stress the gold standard. And, I've been around also with all these minimally invasive treatments that have come around. And yes, some of them have had some pretty good success. It depends on smaller prostate size, etc. The bigger the prostate, the more you need a bigger procedure, and those what we call minimally invasives are not going to do as well. But if you're interested in more information about those, just go to our website at UroPatient.com, and I've recorded several episodes on all these minimally invasives like Optilume and Resume and UroLift and all these other ones that are out there that don't require, they can be done in offices, in doctors' offices. So there are advantages to some of those, especially with just early prostate problems. And then, of course, there's medications you can go on that can help relieve symptoms. But ultimately, you're probably going to need something done more because your prostate just keeps growing and growing. So hopefully you found this interesting. He talked about the couple of pills at the end, and I just wanted to go over that. Antibiotics, because we're doing keeping a catheter in, we just try to prevent any infections, any urinary tract infections. So most people are going to go home on some antibiotic. The other one was this anti-spasm pill that he used. The one he was using is an over-the-counter one called azo. I'm not my favorite one because it turns your urine a really bad orange color, and it can sometimes stain. But there are some anti-spasm pills you can go on. Ask your doctor. If you're going to have a catheter, you might want to have some spasm pills on hand, because worse than the catheter is when you get a spasm. A spasm is like a Charlie horse of your bladder. If you could imagine how bad it feels when you get a Charlie horse, imagine your bladder doing that. So if you have to go home with the catheter, you want to definitely have something to prevent that from happening. So again, I hope you enjoyed this. I'd like to know, put in the comments if you had any questions. Next week, we're going to be talking about those catheters again. Ever wonder how to safely remove a urinary catheter? Or maybe you're a patient or caregiver feeling unsure about the process. Urinary catheter removal can often be done by the patient. And I'm going to go through step by step with you how to remove it. I'm going to walk you through simple, clear, patient-friendly breakdown of Foley catheter removal so you can be prepared for your aftercare. A lot of times patients come into the hospital, we start them on a medication, they go home with the catheter. We like them to pull it out the night before and see us the next morning, and we can see if they're able to urinate. So in this episode, you're going to learn when it's safe to remove your catheter. Don't do it without your doctor's say so. A step-by-step removal technique, what to expect during and after removal, tips to avoid complications, and improve comfort. So whether you're the patient, caregiver, even a healthcare professional, this is a must-watch for building confidence with taking out a catheter. So join me next week for that. And again, thanks for watching, and we'll see everybody next week on UroPatient.com.
From research updates to daily advice, Vic explains it all simple and precise. No question too small, no topic too wide. We're your urology partner, right by your side. UroPatient, tune in and see, paving your health for you and me. Knowledge is power, power. We make it clear every Saturday morning. The podcast is here.